Сейчас. Сейчас это.
Good morning. The topic of our today's lecture is diseases of the endocrine system. You know that our endocrine system includes very more endocrine glands, main from which are hypothalamus and pituitary, thyroid gland. We know about incretory function of pancreas, adrenal glands, pineal gland, and sex gland. But today we'll stop only on two gland pathology, thyroid gland and pancreas. Disordered incretory function of pancreas clinically manifested with diabetes mellitus. You know that pancreas is a gland which has two functions. Exocrine functions, about which we talk with you when we studied digestive system, and incretory function, about which we will talk today. And due to activity of specific glands of the pancreas, such as Langerhans island gland, which produced insulin, level of sugar in our blood will be controlled. Disordered function of Langerhans islands, the beta cells, which activity may be decreased or may be disordered sensitivity of the cells to produce insulin. Patient go to the doctor with symptoms diabetes mellitus. Diabetes mellitus, depending activity of beta cells divided on two types. First type, or insulin-dependent diabetes mellitus, is characterized with depressed activity of the beta cells when the production of insulin significantly decreases and not adequate needed functional activity of the organism, or if the produced insulin cannot be used due to some immune disorders. You understand, this group of patients needed only insulin correction because himself insulin cannot be used for control of blood sugar. Second type or non-insulin dependent diabetes mellitus appears due to decreased sensitivity of the tissue to produce insulin, and in this case, or if the activity of insulin decreased. In this case, we can stimulate activity of patient insulin or increase sensitivity of his tissue to produce insulin. Other words, second type diabetes mellitus not needed in insulin correction. Sometimes in long-standing cases, due to some complications, this group of patients also needed to insulin correction, but it's not obligatory for this patient. First type cannot live without insulin. Second type may be corrected without insulin. Let's stop on risk factors, provoke factors. Insulin-dependent diabetes mellitus, first type diabetes mellitus. Now, first of all, it may be any virus infection or toxic affection of Langerhans Islands, which destroyed beta cells and synthesis of insulin becomes impossible. We must remember about hereditary problems, genetic problems, and some immune disorders when the autoimmune infringement destroy insulin and restrict the action in our organism. Non-insulin dependent diabetes mellitus risk factors. First of all, appears due to abnormal life. Patient with obesity. You know from preceded lectures that obesity provoke factors of atherosclerosis. Patient with unbalanced feeding predilected to second type diabetes mellitus because sensitivity of the tissue to insulin progressively decreases. It may be caused by also some genetic factors and chronic long-standing pancreas diseases because any period of exacerbation, chronic pancreatitis, finish with pathological growth of connective tissue, which restrict activity of normal tissue as excretory such as incretory functions. Diabetes mellitus. First of all, we know it is diseases due to disordered carbohydrate metabolism because insulin regulates level of blood sugar, which is carbohydrate. But it is combined diseases with together with carbohydrate metabolism involved in pathological process all other metabolic process, protein, fat and water, salt metabolism. It's explained why patient with diabetes mellitus has very lot complications sometimes which may be grave for his life. If we are talking about disordered carbohydrate metabolism, it is manifested with hyperglycemia, increased blood sugar, when level of blood sugar exceeds 9 millimole per liter, sugar go through the kidney and may be revealed in urine. We are talking about glucoseuria. Protein metabolism manifested with formation of trophic ulcer, slow healing of the wounds, decreased immune response because no adequate protective function. You know that all our immune bodies, all our tissue obligatory needed normal protein metabolism. Fat metabolism disorders manifested first of all with weight in the patient, progressive atherosclerosis, which manifested with grave complication, fat infiltration of liver, and diabetic coma, which is caused due to circulation of toxic fat metabolism substances. Water salt metabolism appears due to polyuria and as a result loss of sodium, potassium and all other microelements which diluted into the water. Let's stop on main complaints of the patient with diabetes mellitus. First of all, and early signs, it is polydipsia. Patient feels excessive thirst. He drinks 3, 5 or sometimes more liters of water per day. As a result, it's accompanied with polyuria as adequate response of the kidney, which regulate water balance. Then more will intake, then more excrete liquid. And polydipsia and polyuria may be first complaints of diabetes mellitus, on which some patients not pay attention. Other problem, skin itching, and I'll pay your attention. It has specific localization, itching of perineal region. You understand? Patient can go in gynecological, dermatological, urological department. Specific location of skin itching. These three problems are first and early complaints which may be of the patient with diabetes mellitus, and in this case doctor obligatory must control blood sugar. Very easy analysis. Maybe other problems such as increased appetite, bulimia, but it's not correlated with weight of the patient, on which patient also can pay attention. I'll take a lot food, but my weight progressively decreases. Why? Because disordered fat metabolism. Patient feels weakness, no, it is result any diseases, but in diabetes mellitus weakness appears early because our activity tightly correlated with carbohydrate metabolism, because carbohydrates are source of energy. Disordered carbohydrate metabolism, no energy, patient non-adequately fatigue. As a result, decreased work capacity, decreased vital activity. Patient life quality and quantity decreases. On inspection, first of all, patient can enter in hospital with grave condition, other words, in situation of acute complication, comatose stage, and sometimes disease primary established in emergency aid department, because before patient not pay attention on primary symptoms about which I said you. Inspection of the skin of the patient with diabetes mellitus can give some information for diagnosis. First of all, we can see that skin of the patient will be dry, rough, easy scaling, sometimes covered with traces of scratching, because skin itching, if perineal region were more thin and elastic skin, you'll understand it's very easy traumatized. Due to disordered protein metabolism, wounds very slowly heals and sometimes maybe add infectious inflammation and process of healing delay. We can see that the skin of the patient covered with specific inflamed foci. Patient predilected to formation of furuncles. Sometimes maybe some eczematous spots and atherosclerosis lesions. I said you it appears due to disordered protein metabolism and progressive atherosclerosis, which decreased blood circulation. If blood circulation restricted, metabolic process decreased and disturbed because no adequate transport of oxygen, vitamins, and all other elements which needed for normal metabolic process. We can see specific red spots on the face of the patient, which localizes on the cheek and chin. It is called rubeosis, specific red coloration of face, which I'll show you later. We can see specific yellowish coloration of palms and soles, xanthosis, not mixed with xanthomatosis. Xanthomatosis, it is a collection of cholesterol under the skin on the areas of eyelids, elbow or knee. Xanthosis is a specific yellowish coloration of the palms and soles. Will obligatory exam tongue of the patient because why in excessive thirst? Because patient feels dryness in mouth. It may be subjective, it may be objective. When the tongue objectively becomes dry, we can see some fold on the tongue, and when we'll touch it, it resembles toothbrush. It is first signs of hyperglycemic coma. Diabetic solis, specific affection of lower extremities, which appears as chronic complication of diabetes mellitus due to progressive atherosclerosis and obstruction of peripheral blood vessels. It starts from trophic tissues and then spreads on whole solis. It has specific localization, starts from the thumb finger, toe finger. And all patients with diabetes mellitus obligatory will go for consultation of specific surgery physician which studied pathology of the diabetic solis. Patients with insulin-dependent diabetes mellitus due to repeated injection of insulin and chronic complication may be revealed lipodystrophy. Disappears dilution of subcutaneous fat tissue in the areas injection of insulin, i.e. abdomen and hips. Skin immediately lies on the muscles without subcutaneous fat tissue, and we'll see areas of depression. No, each is patient with rubeosis. I said you specific reddish coloration of cheek and chin. Patient with dry skin which loses elasticity and becomes thin. Maybe specific hyperpigmentation, especially in armpit region. It is diabetic solis. I said you it starts from toe finger and then spreads on whole solis and needed surgical correction because it is gangrene, death of tissue due to disordered blood circulation. Some specific recommendation on which patient will go may prevent this complication. Also, patient with diabetic solis, no, it is final stage. Trophic ulcers, eczematous spots also is result of disordered blood flow due to progressive atherosclerosis of peripheral vessels. Lipodystrophy, lipodystrophy, dilution of subcutaneous fat tissue in the areas injection of insulin. And also you see trophic disorders of lower extremities. In summer periods you can pay attention on senile people. You can see brown color of lower extremity skin. It's result of trophic disorders, patient with progressive atherosclerosis, patient with diabetes mellitus, and other metabolic diseases. I said your diabetes mellitus due to involvement all metabolic process and pathological process may be complicated with some specific clinical manifestation. All complications divided on two groups: acute, which is diabetic and hypoglycemic coma. No, next causes when we completely study endocrine diseases, you will study other types of coma. But today we'll stop only two types: hyperglycemic diabetic and hypoglycemic coma. And chronic complications, late complication, which appears due to non-adequate action of the patient, which disturb dietary recommendation, which not correctly take some medicine, especially insulin injection and dosage. As a result, will be formation different chronic inflammation fostered. Patient with diabetes mellitus due to disordered protein metabolism and decreased immune response very often will sick with tuberculosis, pyelonephritis, and other chronic inflammatory diseases. Problem with blood circulation, micro and macroangiopathy, manifested with problem of vision, brain, kidney, lower extremities, heart. Neuropathy due to disordered water electrolyte and vitamin balance, because activity of nervous system tightly connected with some microelements and vitamins. And involvement other organs and system in pathological process. And first of all, there are heart, brain, kidney, and eyes. Now, if we are talking about affection of other organs, respiratory system, involved in pathological process due to decreased immune response and formation of chronic inflammatory foci. I said to you about tuberculosis, pneumonia, chronic bronchitis. Heart, atherosclerosis of the coronary vessels, manifested first of all with attacks of angina pectoris and then myocardial infarction. Atherosclerotic affection of peripheral vessels, manifested with gangrene of the feet, diabetic soles. Locomotor system. Patient can complain on early muscular atrophy and osteoporosis. You understand? Which is provoke fractures of bone fracture. Insignificant trauma may be finished with fracture. You can compare density of normal and diabetic bones. Patient afraid fracture of bones and plus weakness. Physical activity of the patient decreases, plus disordered activity of nervous and circulatory system provoke fracture, muscular atrophy. Gastrointestinal tract and liver. No, first of all, patient with diabetes mellitus predilected to inflamed affection of oral cavity because our oral cavity not sterile and normal activity of immunoglobulin A hold our organism from infections, but activity of immune response decreases of the patient with diabetes mellitus. As a result, inflammation of gums, parodontosis, inflammation of the neck of the teeth, pyorrhea, decreased activity of the gastrointestinal tract gland, hypo and echlorhydria, as a result different dyspeptic disorders, and we said about fat dystrophy of the liver, hepatosis. Kidney affection is called nephropathy, and in disease will show diabetic nephropathy, affection of glomeruli and other unit structure of kidney, clinically manifested with hypertension due to decreased immune response. I said you about pyelonephritis, chronic inflammatory process of kidney. Nervous system affection, different manifestation of polyneuritis, and first of all, patient feels discomfort during walking because pain, paresthesia, anesthesia of lower extremities. His gait becomes not straight, he easily falls, sometimes cannot go independently. Problem with vision, retinopathy, which manifested with exudate into the retina, hemorrhages and pigment abnormality in the yellow spot due to disordered microcirculation, microangiopathy, and patient with diabetes mellitus predilected to specific eyes disease, cataract, decreased transparency. Acute complication of diabetes mellitus. Diabetic coma. You know, coma is unconscious condition. Diabetic hyperglycemic coma appears due to intoxication of the body with acetone bodies due to disordered fat metabolism. Diabetic coma develops gradually. Sometimes pre-comatose state may be during some days. And if the patient informed about it and attentive to himself, he immediately go to the doctor to prevent comatose stage with correction of dosage of insulin. You see, again come back all complaints which are characteristic for disordered carbohydrate metabolism. Patient again feels excessive thirst, drink lot of water, as a result excrete lot of urine, but on contrary from manifestation of diabetes mellitus, primary manifestation when the patient feels bulimia, increased appetite, patient with pre-comatose stage losses appetite, can feel some discomfort or pain in epigastric region accompanied with dyspepsia, can feel headache and different nerve disorders. Patient becomes restlessness, complaints on disordered sleep, and sometimes maybe predilection to convulsion because disordered microelement level and activity peripheral nerve system. If the patient not attentive to this state, nerve excitation change on depression, and then patient gradually loses consciousness. He goes through the whole stage of depressed activity of central nervous system, stupor, sopor, and coma. And sometimes patient enters in hospital with deep comatose stage. What can you see? Patient with diabetic hyperglycemic coma, motionless because unconscious. His face may be both pink or pale color, but skin is very dry. Muscle tone and tender reflexes decrease. Will touch patient, his muscles very soft and any cloth. Sometimes may be revealed pathological reflexes, grasping or sucking. If will touch on his eyeball, they tone also decrease. They are very soft, as will push on pillow. Pupils are narrow. From the patient may be deep noise respiration, mouth respiration, and when will come on to him, we can feel specific acetone smells, odor of rotten apples, due to acetonemia. I said you, cause of diabetic coma is intoxication with ketone bodies, result disordered fat metabolism. Pulse may be low and fast. Arterial pressure decreases. Body temperature decreases because disordered metabolic process. Sometimes may be problem with urination. Diuresis progressively decreases to oliguria, sometimes anuria, due to intoxication, due to decreased blood pressure. Objective signs of hyperglycemic coma is examination of blood on the level of blood sugar and examination of urine. And if you reveal increased level of blood sugar, presence of acetone, ketone bodies and glucose in urine, our disease will be diabetic hyperglycemic coma and patient needed injection of insulin to correct level of blood sugar and come back consciousness of patient and regulate metabolic process. Hypoglycemic coma, on contrary from hyperglycemic, develops faster. Sometimes during some minutes, if you was attentive, I said you, hyperglycemic coma develops some days and has pre-comatose stage. Hypoglycemic coma appears fast, rapidly. Sometimes patient can feel short times, sudden hunger, weakness, sweating, tremor in the entire body. Short time may be overexcited and false. But this process very fast, sometimes some minutes. And patient suddenly falls on the street. It may be of the patient which introduced insulin You must remember, after injection of insulin, patient must take food during 30 minutes. If no, due to activity of insulin, blood sugar drops and patient loses consciousness due to hypoglycemia. Sometimes if you long time not eat, you feel symptoms which resembles hypoglycemia, but it cannot be finished with coma because your carbohydrate metabolism not significantly disturbed. It's only superficial problems due to delay eating. If the patient not take food after injection of insulin, you decide I'll first of all go to the work and then take food. Wait to the work prolong and instead work patient go to the clinic with hypoglycemic coma. What can you see? Skin of the patient pale and moist. I'll pay your attention on contrary from hyperglycemia when skin is dry. Muscular tone and reflexes increases. You'll touch patient. His muscles resemble stone on its density. Due to increased reflexes, comatose stage accompanied with convulsion and sometimes may be assessed as epilepsy or any other convulsive diseases. Eyeball on touching also firm, on contrary from hyperglycemia. Pupils dilated, but objectively we can establish disease only after examination of blood sugar. Into the blood sugar decreases, urine, no problems, no acetone, no glucose. It is characteristic for hypoglycemic coma, and this patient needed emergency aid, injection of hypertonic solution of glucose, sometimes 40 millimeters of 40% glucose, enough to come back patient to consciousness. Now let's again stop on differential diagnosis symptoms diabetic and hypoglycemic coma, because this question will be given separately on exam. First of all, we'll pay attention on development, and we remember gradual development through the pre-comatose stage for diabetic coma and fast, rapidly for hypoglycemic. Skin dry, moist. Muscle tone and reflexes decreased in diabetic and increased in hypoglycemic to convulsion. Eyeball tone, same correlation, decreased in diabetic and increased in hypoglycemic condition. Breathing of the patient, diabetic coma, predilected to Kussmaul, loud, slow breathing with acetone smell, and normal breathing for hypoglycemic condition, and obligatory urine and blood analysis. It may be assessed immediately because we have specific fast test which shows present or absent acetone into the urine and show level of blood sugar. In diabetic coma, glucose and ketone bodies in urine presented, hypoglycemic, no, and obligatory level of blood sugar into the blood. Let's stop on the way of diagnosis. Diabetes mellitus. It's not difficult because first of all we must control blood sugar of the patient on an empty stomach. Usually it's varied from 3.3 to 5.5 millimole per liter. I'll pay your attention each is index for examination of capillary blood. Last time we'll examine venous blood and level of blood sugar will be slightly higher to 6 millimole per liter. No, when you will work in any hospital, you will be oriented on itself laboratory indices because it depends from reagent and from the order of examination. Capillary, venous blood, what reagent are used for determination. But on exam, will oriented on these indices will be changed, you will correct your knowledge. If the level of blood sugar on empty stomach increased, we are talking about glycemia on empty stomach, and send our patient on glucose tolerance test. Will control response of the organism on glucose loading. Again, normal level of blood sugar, if it's increased, we are talking about glycemia on empty stomach and send our patient on glucose tolerance test. If the blood sugar on empty stomach not exceeds 6.9 millimole per liter. Next day, patient again come in laboratory. We'll take blood on empty stomach, then we'll give him some glucose diluted in water, and after sometimes 1 hour we'll control blood sugar. Normally, we'll remember sugar in the blood on empty stomach must be less than 5.6 millimole per liter. If more, we are talking about glycemia on empty stomach. If the blood sugar on empty stomach more than norm but not exceed 6.1 millimole per liter. And glucose tolerance test less than 7.8 millimole per liter. This patient needed dietary correction. No, and correction of weight and physical activity obligatory. If the blood sugar increase on empty stomach, but glucose tolerance test less than 7.8 millimole per liter, our conclusion will be glycemia disturbance on empty stomach. This patient needed some dietary correction. It is pre-diabetic state. If the glucose tolerance test more than 7.8 but less than 11.1 millimole per liter, we are talking about disturbance glucose tolerance. It shows that sensitivity of the tissue to insulin disturbed or non-adequate activity of insulin. This patient sometimes needed medicamentouse correction because it may be initial stage of diabetes mellitus, disturbance glucose tolerance. And in case when the glucose tolerance test more than 11.1 millimole per liter, we are talking about true diabetes mellitus. And this patient obligatory needed only medicamentouse correction. But we must know what medicines, because we remember about first and second type diabetes mellitus. Patient obligatory go to next examination, which helps clear type of diabetes mellitus. We can check level insulin into the blood. If it's low, which is first type. If it's normal or increased, which is second type, because present with insulin, but tissue not response on its result. C-peptide, widely used test because it's primary insulin fraction, which also decreases in first type and normal or increased in second type. We can send our patient on insulin antibodies if we think about some autoimmune disorders, and glycemic hemoglobin. It is used for diagnosis and for control of treatment diabetes mellitus. Normally it's varied from 4.8 to 6%. Will clear disease, will prescribe patients some medicines or give some dietary and life recommendation. This patient needed to control. Because if the patient holds level of blood sugar on definite level, he will prevent acute and late complications. For control, we'll use glycemic profile. No, first of all, it is needed for the patient with first type insulin-dependent diabetes mellitus. When we'll control blood sugar 4 times per day, for example, 8, 12, 4 and 8 hours, AM and PM. With usual order of life, we'll check activity of insulin, and if level of glucose increase or decrease in definite time, we'll correct dosage of insulin morning, daily or evening time. Give short or prolonged time action insulin. Glycemic profile is needed for the patient with first type of diabetes mellitus to correct dosage of insulin. Obligatory will control urine on glucose and ketone bodies to reveal early stage of decompensation. And I said you about glycemic hemoglobin. Because if the level of glycemic hemoglobin is known, it shows that diabetes mellitus is controlled. Our treatment is correct and patient response adequate. If no, long talking with patient which explain him about needed adequate response. Next problem on which I want to talk today is thyroid gland diseases. You know that thyroid gland is one of main endocrine gland in our organism, together with pituitary, hypothalamus, because depending its activity will be dependent activity of some vital organs, and first of all cardiovascular system activity. And sometimes patient first of all enters in cardiovascular department, and then doctor reveals that problem started from thyroid gland. I'll remember you anatomy of thyroid gland, which localizes on the level of thyroid cartilage and has two main structure, isthmus and lobes. Normally thyroid gland invisible and impalpable. We'll study pathology of thyroid gland, and you can easily understand and answer this question if you remember main problem which may be of the patient with disordered activity of thyroid gland. First of all, will be problem with nervous system, cardiovascular system, some problem with activity of gastrointestinal tract, and secondary endocrine disorders. Because we remember thyroid gland is one of main glands of endocrine system which control activity of other endocrine organs. Two problems on which we'll stop today: increased and decreased activity of thyroid gland. Increased activity of thyroid gland, thyrotoxicosis, we will study on example diffuse toxic goiter or Bazedov disease. Provoke factors or reason formation of thyrotoxicosis. Maybe some psychic trauma, must be severe psychic trauma, which maybe provoke factors beginning of thyrotoxicosis. It may be result of some heavy infectious process. It may be due to central genesis dysfunction of pituitary because activity of thyroid gland control with pituitary enzyme, thyrosensitive hormone, and as always we remember about genetic family factors. Clinical signs of diseases with which patient can come to you. We remember, we'll orientate on three systems: cardiovascular, nervous, and digestive. And more often, manifestation of disease start from pathology of cardiovascular system. Patient feels palpitation, sometimes different types of arrhythmias with which we go to the doctor. On examination, doctor can reveal enlargement of the thyroid gland, or patient can feel independently discomfort in the neck area or deformation of neck. Patient can go in neurological department, especially patient which needed clear movements in his walking activity. Patient can go to the ocular department because some problem with vision and some digestion disorders. And all complaints will also divide on this system. From cardiovascular system, I said you, palpitation and arrhythmia. Patient feels increased psychic excitability and increased reactivity. His behavior becomes non-adequate, exceed definite situation, non-adequate response. Patient feels non-motivated anxiety. As a result, will be deranged sleep. Maybe tremor, first of all on the fingers, and then entire body. Patient predilected to sweating, hyperhidrosis. May feel some increased body temperature, not significantly, subfebrile, 1 degree above norm. Muscular weakness. There are results disordered activity of nervous system. You see as rich symptoms, but sometimes will not pay attention on these symptoms long time, and sometimes only family pay attention that some people becomes non-adequate in his response on some situation. From digestive system, due to increased activity of gastrointestinal tract, patient predilected to diarrhea, progressively loses weight, but feel high appetite, and sometimes can feel discomfort of the neck region about which I said you. You see, we divided all problems of patient on three main groups: cardiovascular, nervous, digestive. What can you reveal? First of all, we'll pay attention on special behavior of the patient. his behavior non-adequate. Which is revealed on common inspection. Then will obligatory pay attention on examination of neck with inspection and palpation to assess size and consistency of thyroid gland. Will check ocular symptoms which are specific for thyrotoxicosis and examine cardiovascular system. And question about examination of cardiovascular system of the patient with pathology of thyroid gland will be given as separate question. Now let's see. First symptoms, when the patient only come on in doctor room. We can see that patient motor restlessness. No, usually patient come in, sit down and talk about his problem. This patient very fast come in, sit down, stand up, can go around your table, around you, then again sit down. Non-adequately restlessness. Patient fuzziness. Patient cannot control his emotions. Nervousness. Fidgetness. His mood very fast change during some times during which he talk with doctor some minutes. His psychic state may be change from excitation to depression. He predilected to tearfulness without any order. His speech is very fast and not continuous. He cannot long time hold object of talking. He can start talk about one problem, then drop it and go to other problems. Not continuous speech. And our attention will be paid on specific face appearance, facies basidovica, which is characterized with specific clinical characteristic. Now you see special behavior features, primary, first of all, dependent from problem with nervous system. What is facies basidovica? You see, patient is looked as he seen anything not typical for our life. Widened eyes with rare blinking give specific behavior of the thyrotoxic patient. We are talking about facies basidovica. Common inspection. No, first of all, reveal predilection patient to decreased weight. In grave cases, maybe cachexia. Skin of the patient is smooth as result and moist. As a result, patient looked younger, his age, due to increased elasticity of the skin. If we'll touch it, it will be warm. You see, I separate with index because it's not inspection, it's just palpation. We can see diffuse pigmentation, especially near the eyes, hyperpigmentation. And it also gives specific facial behavior. Hair predilected to false and very, very thin and soft. We can see tremor of finger. If it's invisible, we can check it if ask the patient strain his hand and put some paper, which visibly moves. Positive Marie syndrome. Local examination. Neck examination, first of all. I said you normally thyroid gland invisible and impalpable. If gland invisible, but we palpate its lobe, but its size not exceed 1/phalanx of thumb, finger of patient, not doctor. We palpate lobe of the thyroid gland and put finger of the patient to determine its size. We are talking about 0-degree enlargement of thyroid gland. In 3rd degree, size of thyroid gland more than 1/phalanx of thumb finger, and it may be slightly visible due to protrusion over the position of thyroid gland. And 2nd degree, when the visible deformation of the neck due to formation of goiter. Thyroid gland, depending its size, divided on 3 degree. 0, invisible, may be palpable, but its size not exceed 1/phalanx of thumb, finger of patient. 4th degree, slightly visible and exceed 1/phalanx, and 2nd degree, easy visible. Now you see patient with 0-degree, no problem with neck, thyroid gland will be revealed only due to palpation. Which is 2nd degree, because visible deformation of the neck due to enlargement of thyroid gland. Also, which is 2nd degree, because significant visible deformation of the neck due to enlargement of thyroid gland. Ocular symptoms. Ocular symptoms. We'll check specific ocular symptoms which are characteristic for thyrotoxicosis. And this question also will be given separately on exam. Check ocular symptoms. First of all, we'll pay attention on bilateral dilation of the eyelid, which is initial stage. Then we can see that eyeball protrudes upward. We are talking about exophthalmos, progressive affection. We'll pay attention on reblinking, Stellwach signs. Patient see and he's looking stop. Usually we'll periodically blink to moist our eyeball and hold it from infectious. Stellwach signs, reblinking. Greffe, Kocher and Möbius signs will be checked with specific action of doctor, because only see not enough. We must do some manipulation. To take these signs, we'll ask the patient to fix some subjects. No, it may be pen, it may be finger of the doctor, and we'll control movements of eyeball depending movements of our subjects, because Greffe-Kocher signs will be formed due to disordered movements of the movements of eyelids and eyeball, ocular motor dysfunction. Möbius signs, which is control convergence, how patient can fix some subject. Now you also see, first of all, widened eye slit and protrusion of eyeball, exophthalmos, which is seen from lateral direction. Due to reblinking, you see secondary inflammation, because no adequate moistness of the eyeball and easy secondary infectious process. You see problem with convergence, asymmetric position of the eyeball. Sometimes maybe predilection to ptosis. It may be characteristic for patients with thyrotoxicosis, also due to some ocular motor problems. Let's see how we'll check Griffith signs. Ну, у меня же лекция. Совсем дурак, что ли? Griffith signs. Let's see how we'll check it. I said we'll put some subjects nearest on the level of nose of the patient, and I'll pay your attention on distance 25 centimeters, which is optimal distance for vision, and ask the patient fix this subject only with eyes without movements of head. And when we'll move subject downward, eyes of the patient also synchronously go downward. Normally, movements of eyeball and eyelids completely synchronous, and upper eyelids must lightly cover the eyeball before iris. If you see on this picture, you see that between upper eyelids and iris we'll see white strip, because movements of eyeball faster than eyelid. Eyelids delay from eyeball. Positive Griffith signs, which is normal position. Patient look downward, eyeball and eyelids go synchronously. Eyelids delay. We see white strip between upper edge of iris and upper eyelids. Positive Griffith signs. Also you see positive Griffith signs. Coher signs will ask the patient fix subject which will move upward. And again, normally, eyeball and eyelids move synchronously, and upper eyelids always cover the eyeball before iris. Patient with thyrotoxicosis, eyeball delay from eyelids, and again we see white strip between iris and upper eyelids. Same signs. White strip between eyelids, upper eyelids and iris. But if it's revealed when the patient looks downward, positive Griffith. When upward, positive Coher. Melitus signs will move subject to the tip of nose, and normally both eyes go inside and stop. Fix subject. Patient with thyrotoxicosis cannot fix subject. Eyeball go inside and then one eyeball come back. Asymmetric. No convergence. Disordered convergence. You see position of eyeball not symmetric. Positive Melitus signs. Patient cannot fix subject and accompanied with ptosis. Cardiovascular system problem starts from subjective discomfort. Patient feels palpitation, sometimes arrhythmia, due to toxic effect of the thyroid hormones. Patient can complain of headache because increased blood pressure. He go to the doctor and on auscultation will reveal snapping first sound because increased contractive activity of the heart, increased muscular component. We can reveal tachycardia and different disorder of heart rhythm from extrasystole to atrial fibrillation because thyroid enzymes increased activity of heart, increased blood flow, increased heart contraction, fourth, increased heart rate. We can hear systolic murmur. It may be heard only locally over heart apex due to decreased tone of papillary muscles and formation of relative mitral valve insufficiency, because due to low tone of papillary muscles, one caps of mitral valves go downward or upward, and through the small slit, blood easy come back into the left atrium with turbulent audible movement. Systolic murmur may be heard over all heart points. It shows problem with blood flow. Due to increased blood flow, it goes with audible turbulent movement. You see, depending location of murmur, we can think about some or other problems. And I said you about high pressure, but it has specific characteristics. Systolic pressure increases, but diastolic falls. As a result, will be high pulse pressure due to increased activity of heart contraction and mass of the circulating blood. It's example of the blood pressure patient with thyrotoxicosis. If you was attentive, it resembles pressure of the patient with aortic heart defects, aortic regurgitation. Digestive system. No, first of all, patient feels increased appetite, predilected to diarrhea due to increased motor function of intestine. If its function increased, no time for adequate absorption of the food and not dependent from appetite, patient progressively loses weight. Patient with thyrotoxicosis predilected to some liver diseases, from hepatic dysfunction to liver cirrhosis. And I said you about involvement other endocrine organs, and first of all, hyperthyroidism, depressed activity of sex gland. Women have problem with pregnancy due to disordered menstrual cycle. Will be depressed activity of adrenal cortex gland. Will be some problem with mineral metabolism due to hyperadrenocorticism. And maybe secondary diabetes mellitus due to depression activity of Langerhans islet beta cells. As a result, synthesis of insulin. Hypofunction of thyroid gland. I will study on example of myxedema, hypothyroidism, myxedema, and if you remember patient which I showed you on basal disease, hyperthyroidism, it differs from the patient with hypothyroidism. Primary hypothyroidism appears due to abnormality of thyroid gland or its chronic, progressive, prolonged inflammatory diseases when the activity of thyroid gland decreased due to abnormal growth of connective tissue. It may be result of thyroidectomy with primary hyperthyroidism. Sometimes it is corrected with surgical method, or result of activity of ionic radiation. Secondary hypothyroidism appears due to pathology of thyroid gland which secrete inactive thyroid enzymes. It may be some congenital or some immune disorders. You remember from our first lectures that hypothyroidism, which started in early young period, accompanied with delay physical and psychic development. As a result, patient will be with mental delay. We are talking about cretinism. Complaints of the patient, opposite complaints of hyperthyroidism. Same system, but If hypothyroidism characterized with increased activity, hypothyroidism will be characterized with decreased activity. Patient loses interest to surroundings, complaints of apathy. As a result, impaired memory, decreased work capacity, predilection to sleepiness, somnolence, flaccidity, and chill, because metabolic process decrease. And if you remember and understand problem of thyrotoxicosis, hypothyroidism, very easy answer. Opposite problem. Depression, activity of nervous system, cardiovascular system, and digestive system. On inspection, also will be specific patient appearance. His face may be puffy, but it's not true edema. It's collection specific protein substances. Skin pale, sometimes with yellowish hue. Eyelid narrowed, eyeball depressed. Skin of the patient will be dry and thick, predilection to scaling, will be rough and cold due to touch, and again I separate it because each is palpation. No, sometimes skin of the patient with hypothyroidism correlated with elephant skin. Hair of the patient easy falls, as a result becomes rare, and sometimes no growth of the hair on the face. And behavior of patient also specific. On contrary from thyrotoxic patient with hypothyroidism, slow, his speech is monotonous, non-interested, he only answers on your questions yes, no, slowly without any interest. You see patient with hypothyroidism. Skin is rough, thick, like elephant skin. And again, I'll pay your attention on cardiovascular system, because this question will be given separately on exam. Blood minute volume and blood flow decreases. As a result, patient feels weakness. It's explained because bradycardia, slow blood flow, slow metabolism. Heart sound becomes dull. Blood pressure decrease, especially systolic pressure. Diastolic pressure may be near its norm, but will be decreased pulse pressure. And we know that pulse pressure regulates filtration of urine, kidney activity. For example, a low level of norm, but patient feels subjective discomfort. Gastrointestinal tract, due to low activity, patient predilected to constipation, meteorism, obesity. Function of the gland decreases, but due to slow movements, all food slowly but digested and absorbed. Patient predilected to obesity. Nervous system. You saw primary signs of hypothyroidism manifested with depression of nervous system, but if the level of enzymes significantly decreased, may be complications such as psychosis, overexcitation, and sometimes patient enters in neurological department with some radicular pain, especially problem with extremities. Patient feels paresthesia, predilected to cramps. As a result, his gait becomes shaky, not straight, because no adequate sensitivity. Principles diagnosis. thyroid gland diseases. No, I said you, thyroid gland is one of main endocrine gland, but its function controlled by activity of hypothalamus and, first of all, pituitary due to synthesis thyrosensitive hormone. And we'll start diagnosis of thyroid gland diseases from determination of serum thyroid sensitive hormone or thyrotropic hormone, which level correlate inversely with active thyroid hormone concentration and represented the best single index to the diagnosis primary hyper or hypothyroidism. From physiology, you know that between thyrosensitive hormone and active enzymes of thyroid gland T3, T4 presented opposite correlation. If the level thyrosensitive enzyme increases, level of thyroid active enzymes decreases and opposite. And if we reveal decreased level of thyrosensitive hormones with blood radioimmunoassay method, each indicates about primary hyper or hypothyroidism. Sometimes it may be enough, but to clear and differentiate, we'll send if the level of thyrosensitive hormone increases, which is characteristic only for hypothyroidism. In case of decreased thyrosensitive hormones and differentiate hyper and hypothyroidism primary origin, we'll send our patient on examination active enzymes of thyroid gland T3, triiodthyronine, and T4, thyroxine. And if its level decrease, it is hypothyroidism. If its level increase, it is hyperthyroidism. We can examine basal metabolism, which is method when the patient examined in special room with special temperature and pressure without any physical activity. No, this method last time rare used in some practice, but you can be oriented in them. Normally it's not varies from norm, and norm dependent from special table, depending of weight, height, sex of patient. But if it exceeds 50%, it's sometimes 100% from norm increases, which is characteristic for hyperthyroidism. Opposite correlation, hypothyroidism. We said about predilection of the patient with hyperthyroidism to subfebrile temperature, and will obligatory send our patient on ultrasonography to assess size and structure thyroid gland, and radioisotopic scanning, which shows functional activity of thyroid gland. And due to collection of radioisotope into the tissue of thyroid gland and increased level into the blood, we can assess function of thyroid gland. For example, for radioisotopic examination, we'll use iodine, which will be introduced, and then we'll put special apparatus over projection of thyroid gland and control level accumulation of the iodine into the thyroid gland, which must be 7-12% after 2 hours and nearly 30% after day. Which is normal curve. And you understand, if the thyroid gland very fast accumulate iodine, we are talking about hyperthyroidism. Opposite, slow accumulation is characteristic for hypothyroidism. That's all today. Thank you so much for your attention. Be healthy. Meet next week. Goodbye.